Uh, and my gratitude to the officials of Nepal Society of Radiology for arranging such beautiful conferences and BIMSTEC sessions, and respected all the participants from Nepal and as well as abroad. Our all training, seminar, symposium, all are to increase our precision. But still, in spite of precision, we have some errors. And that's why in the next 13 minutes, we will focus on radiology errors. What is error? What are the types? And how to mitigate errors. So error types. Error actually the difference between observed value and true value. And in the radiology, you can think it's what radiology sees, but what this is actually. The difference, the discrepancy between this is error. And the data shows 3 to 5% of all our report has some error. But if we see retrospectively, it is more bigger, 30%. And most of these are cognitive and perceptual error, and malpractice claim are majorly due to the radiological errors. And the types, the different types, that the perceptual error is the most common, around 60%. There is lesion in the film, visible, but radiologists miss it. That is, lesion is there, but we miss it. We fail to perceive. And the cognitive error, the lesion is detected by the radiologist, but the brain failed to interpret it, wrong interpretation. And there are some other errors like communication error, the typing error, administrative error, knowledge-related error, there are so on, different errors. But the most commons are perceptual and cognitive. And what are the causes of perceptual error? There are the subtle findings. The findings sometimes so subtle that radiologist eye miss it. And sometimes lesions are within the blind spot, different blind spots in the film. And the radiologist suffers from satisfaction of search and due to the increased workload. This is the example of subtle findings. The subtle X-ray shows subtle fractures in the smaller bones so that radiologists miss it. This is the example of satisfaction of search. There is a nodular lesion, semi-subsolid lesion. If the radiologist fail to more search, then there are other lesions like these are the pulmonary thrombus and another lesion in the left apical lung. So the multifocality of the lesions, we have to search all the fields. And sometimes lesions are too smaller and it can be missed. One lesion, hepatic small nodules, is missed. So if we don't look the subsequent series, it can be missed. Sometimes lesion missed in very subtle in the CT image, but very obvious in MR image. And these are the hidden blind spots in CP angle. It is very subtle, but in MRI it's very clear. Again, in the brainstem, it may be artifact, but in diffusion image it is obvious, acute infarct. So these are the blind spot, examples of blind spot. In the brain, there are some blind spot like in the sulci and the brainstem, the posterior fossa, clevus, skull base, and the orbits, Mackay's cave. These are the blind spot. And similarly, in CXR, there are some blind spot like lung apexes, above the clavicles, the retrosternal area, the below diaphragm. These are the common areas of blind spot that we miss lesions. This is the example of blind spot, and the apical nodules was missed, which was confirmed in CT image. And sometimes brain suffers from biasness. It is a shortcut. The systemic deviation, it is our thinking, it is beyond our control. We brain always use some shortcuts. And seeing what we expect to see, our eyes will see that. This is the biasness. And this is the context of biasness. Our brain has some preloaded programs like attitude, memory, learning, perception. These are all of the preamble. So that, and again, what we see in the cube, but brain interprets as a circle. So this is the biasness. Brain uses shortcuts. And that the common biases are availability bias, anchoring bias, confirmation bias, and premature closure. These are the examples of availability bias. Such interpretation is in case of COVID era, some radiologists should definitely interpret as COVID pneumonia, but actually it was dermatomyositis associated pneumonia. And anchoring bias, a patient has a given history of multiple myeloma with chemotherapy. If you see this one, so any radiologist should interpret as a metastasis, but it was not metastasis, it's compression fracture. So this is the anchoring bias, the stiffness to initial findings. And satisfaction of search, again, it is lung window seeing some reticulonodular opacity, but we see the soft tissue window, there is bone erosion. And failure due to lack of knowledge. Such types of lesion can be misinterpreted as sarcoma, but if you see very closely, it is rather vessels. So this is angiomyolipoma. Again, the McCa's cape, very subtle lesion, but in contrast image, we can see the enhancing lesion. It may be meningioma. And sometimes we fail to suggest appropriate exam. There is a paracardiac shadow. But in angiogram, there is aneurysm. And sometimes technical errors occurs. If you see these types of bone window, the subtle horizontal oriented fracture will be missed. So we need 3D image to detect the horizontally oriented fractures. And the proper windowing, we cannot see this dissection here. So the soft tissue and brain window is, and again, this is stroke windowing. We can see the lenticular opacity, lenticular hypodensity. And sometimes we fail to communicate the urgent findings to the clinicians, like the pulmonary embolism, the fetal emergency, like ectopic pregnancy, which needs urgent medication. So we fail to communicate the findings to the clinicians. Sometimes we produce unclear reporting, ambiguous reporting, maybe suggestive of like this. And sometimes we fail to recommend follow-up exams. So these are all of the source of miscommunication. And one big thing is a typing error. That we work with the typist, they are not that much educated. So if we see them, if we to write left, they can go to the right, they can interpret as the right. So there is some mistake, word substitution, omission, insertion, spelling mistake, even right to left spelling mistake. Sometimes gallbladder is operated, it is reported as gallbladder is normal in size. It's a common phenomenon. So sometimes it is a typing mistake. And this, we know, the mistake, great mistake in 1994 World Cup. We have the who are like my age. This is the famous mistakes. What happens? Zinedine Zidane and Materazzi headbutt. He gained the red card, and finally, the Italy lose. France loses the World Cup. So the Swiss chess model of error. The Swiss chess model states that every system has some different layers, and each layer has some weakness and strength. When every weakness stand up in the same line, then the major error occurs. So our duty is to seal all the holes. If not, one layer should cover by another layer. So this is the Swiss chess model. And the consequences error is stand from minor to major, to no harm to the patient, minor, intermediate, and major. And of course, lawsuit. So we will face the law claim from these errors. And now, how to mitigate errors? As the error is the fundamental part of brain cognition process, and every system has some fallible things. So we cannot eliminate the error totally, but we have to reduce the error. So our target is reduction rather than elimination. We cannot eliminate. We will reduce. We will claim that we do the minimum error, but we do not do error. It is not our claim. Error, human is fallible. So to err is human. And the error is not done by the angels. So we are not the angels, we are rather the human. So our target is not elimination, rather than reduction. So how to reduce error? There are different approaches how to reduce. These are the systemic search pattern. We'll search our films in a systemic way, the different algorithm, brain, and the chest. We will see the main things, then the hidden areas, then the blind spots, then the double read area, so that we will develop our own system. And the structure reporting, we'll report the structurally. The structure reporting format is nowadays favorite. So you will use the structure reporting pattern and the different pi rates, this algorithm, these lexicons we'll use, and sometimes double reading. We'll use, we'll team like approach. Our juniors, our fellow, our resident should be there in our side. He will primarily read, then we'll interpret it. This culture will definitely reduce their error and improve communication to our clinicians. It is very important. So the clinical findings, important data, so that a different clinical scenario, we heard the clinical scenario, then our diagnosis pattern will be changed. And both the clinical input and we will give them output, the urgent findings, so that it will create a good culture to reduce the error as well as the good communication. And definitely continuous education will be in, we always will be in the learning mood, so that our reduction of the error will be possible. And we will create a resilient system. The hospital authority, the radiologist, clinician, our staff, supporting staff, and the computer operator, customer care, all we are surrounding the patient to improve our service pattern. So a resilient system we have to build. And the solution of non-professional factors like taking regular breaks and breath, it will increase our neurotransmitter concentration in the brain, and the moving and standing while the reporting, and the minimizing phone calls. The phone calls sometimes distract us, so that no use of mobile cell phones while reporting, no see the browsing the internet while reporting, and the height adjustable desk, the lesion and the film and eye should be in the same horizontal plane, not top, below or above. It will increase the lesion conspicuously, and adjusting the brightness, adjust the brightness so that contrast is increased, and reduction of the noise. Our room should be soundless as well. And every error is a lesson. Every error is a lesson for us. We learn from the books and from the degree, from the training, and we learn also from the error. Error is a good source of our learning. So it increases our self-awareness, it shows what is the systemic weakness, adaptability and stakeholders' role, and problem solving and empathy. And we know the discovery of the penicillin was also an error. It was error. The Alexander Fleming erroneously put the mold, fungus mold, to his dishes, but then the penicillin was discovered. And again, the discovery of X-ray was also an error. In the Ranjan's room, accidentally was photographic film was there, and he saw that there is a darkening by the fluorescence. So error is not always bad. Error sometimes good. If we do our works very good way, then error can be a source of our knowledge. So how can we do better? The only one sentence, only one thing we can do, this is we will do our things in best possible way, so that we can reduce our error. This is the only one mantra. We will do our every jobs in best possible way. So by this way, we can reduce our error. We can increase our role in the radiology. We can be in the central part of the radiology. So that's all. Thank you very much for patient hearing. Thank you, sir.